Hi, I'm Lisa. I am with the SHARE project here in Haywood County, and we've been doing a series of interviews in the area with resources, treatment centers, those kinds of things. As you know by now, SHARE stands for Spreading Hope and Awareness and Removing the Epidemic Stigma. And we have been trying to hit each of those topics in these interviews: spreading hope, spreading awareness, removing the stigma. And today's interview does touch on all three of those. I am speaking with Brian Goodlett today. He is a resource, a treatment facility in the area. So that is spreading awareness. We're spreading hope because it is a treatment facility. So there is hope for treatment. And we are just plain talking about addiction, treatment, and the options that there are for people. So we are doing our part to destigmatize addiction and substance use. So again, I am with Brian Goodlett. He is with Pisgah Recovery Services, fairly new facility to Haywood County. It is a facility that is geared towards medicated assisted treatment. Medicated assisted treatment is not new. It has kind of gained some ground, gained some popularity, which I kind of hate to use the word popularity, but gained some ground as being they coined the phrase gold standard for opioid use disorder. So we're going to hope that Brian not only tells us about the treatment facility, what they offer here, but also educates us a little bit on medicated assisted treatment, its benefits. Are there any downfalls to it? So anyway, I'm going to let him tell us a little bit about himself to start with, how he got Pisgah Recovery Services started in the area, and then we'll dig in and hopefully you can educate us a little bit.
Okay, great. My name is Brian Goodlett. I am co-founder and program director here at Pisgah Recovery Services. I have been working in the field of opioid treatment for over 20 years now. Wow. 21 years to be exact. Wow. And I started out, my background, my training was in counseling. I started out as a counselor and just kind of worked my way up, and have been running, managing programs now for the last 16 years. So, my business partner and I, we really saw a need in this area for additional services, which is why we decided to locate here.
Are you from Haywood County then, or are you from Western North Carolina?
So originally I was born and raised in Greenville, South Carolina, but I went to school at Western, did my bachelor's there, and lived most of my adult life in Western North Carolina, some of it in Haywood County. Okay. So spent the last 4 years out in New Mexico, and then came back here, and so it's good to be home.
Okay, yes. So what got you started in the field then, even of counseling or the treatment facilities? Do you have a background with substance use yourself? Anybody in the family? What got you started in this particular thing? So,
the path is long and winding, okay. As they say. There's significant family history of addiction. My family of origin. It was also, as I was going through school, was just something that interested me. So I had an intellectual interest in it as well, and I am personally a recovering person. Okay. So it hits
congratulations. Yes, absolutely. So that's what gives you your foundation then. Yeah, right. Absolutely. Yes. All right. So, and then you said you started Pisgah Recovery Services. How long have you been here?
So we opened in March of this year, okay. 2 weeks prior to the shutdown.
Oh mercy.
rough time to open a new business.
Yes. Yes, absolutely. And you said this is the first time you've actually run a facility, or?
Oh no, I've been running facilities, for like I said, 16 years, I think.
Okay.
This is, the first one that I've been more than just an employee.
Right.
That I'm personally invested in.
Right. What kind of background do you have to run a facility? Any specific? Do you have to have like a medical type background, or you just have to meet certain criteria?
No, the background to run a facility, it really helps if you have somebody who's knowledgeable, in substance use disorders, behavioral health, but as far as what's actually required, there's not a lot of there's a lot of paths you could take to get to this point, but for me, I feel like it's good if you come into it with a with a background at least in behavioral health and substance use disorders.
Makes sense, yes. Okay, so tell us a little bit about Pisgah Recovery Services then. What are some requirements? So when somebody walks in the door, are there requirements? Do they have to be sober at the time? Tell us a little bit about what that first walk in the door would be, or first reach out to you.
Okay, sure. So, we do admissions on Tuesdays, Wednesdays, and Thursdays, and we will schedule appointments. We'll take people walking in. We really try to meet people where they're at when they're ready for treatment. So we do our best to get people in, in whatever way we can. As far as what's required, the only real requirement is that they have a primary diagnosis of opioid use disorder, and they have to be over 18 or up. Okay. So we're not able to treat minors. And at this time, I'm working on contracting with Medicaid and Medicare for the facility, but at this time, all our patients are self-pay. We only charge $1 a day for the first 30 days to allow people time to, see if this treatment is right for them, and to give them some time to, be able to, adjust their budget, so to speak. Right. We are, like I said, I am working on contracting with Medicaid and Medicare so that we can, bill third party.
Right. Do they have to be off their drug of choice before they get started?
No.
Okay, no. So they can.
And there's a myth that's out there, which I would like to go ahead and dispel, which is that someone has to be in withdrawal at the point that they come in for admission. That is not true. People do not have to be in withdrawal to enter treatment. We simply have to be able to, document and diagnose someone with an opioid use disorder.
Okay. Thank you for that. Yes. All right. So, define medicated assisted treatment for us, if you would. In a nutshell. If that's possible.
In a nutshell, medication-assisted treatment is using, medication, and also having supportive behavioral therapies and linkage to other resources and care as part of a comprehensive program.
Right.
So you have the medication, you have behavioral therapy, and then referrals and linkages to other providers for needs that we can't necessarily meet in-house.
Yes. How does the medication work?
Okay, that's a good question. So What the medication does is, and again, kind of dispel some myths. The medication basically stabilizes the person. Okay, it prevents them from going into narcotic withdrawal. And what does narcotic withdrawal look like? Narcotic withdrawal, if you've ever had the flu, okay, looks like the worst case of the flu you've ever had times 10. Okay, it's a miserable experience for people, and and the reason people can't quit is because if they stop using, suddenly they're going to be in a great deal of suffering. It's our nature as human beings to seek relief for pain, for suffering. So, that's why most people just can't stop. That's why this is the most effective form of treatment, because we provide them medication which does not get them high. Okay? They do not experience the euphoria that they would get from heroin or pain pills or fentanyl. So they don't have the euphoria that goes along with that because of the unique kind of pharmacology of methadone. But it stabilizes them, and it allows them to not have to go through that narcotic withdrawal, and to be able to function and to participate in counseling and in various pursuits related to their recovery.
So what types of MAT, medicated assisted treatment, are there? You mentioned methadone.
Yep.
What are there, and then what do you offer here?
There's 3 federally approved medications. There's methadone, there's buprenorphine, and there's another drug called naltrexone. We offer methadone and buprenorphine. Naltrexone is still a very expensive medication. It's relatively new, and each medication has particular characteristics that may make it more appropriate for one person than another.
Is there one that's more effective than another, would you say, or is it just differ according to what works for the person?
Well, as far as track record goes, okay, methadone by far has the longest, most established track record as being effective at treating this form of addiction. The other 2 medications, again, there may be certain characteristics, of an individual that make them more appropriately suited to either buprenorphine or naltrexone.
Why is methadone in particular, and maybe not just methadone, you might correct me if I'm wrong, why does somebody have to come to a facility to take it? Why is it so tightly regulated and distributed? Can you answer that? Why someone actually has to come to a specialized facility to get it?
So yes, the way we are licensed, we are a federally licensed opioid treatment program. Okay, and opioid treatment programs are the only type of provider authorized to prescribe methadone for the purposes of treating addiction. Doctors can't do it out of their offices, and this is where I'm gonna get on my soapbox a little bit. Okay, we got into this opioid epidemic by overprescribing.
Mm-hmm.
We got into it by lack of oversight, lack of physicians monitoring their patients. That's how we got here. Okay, so the reason that this program is more effective and why the patients have to come here is because that's what we do. We provide oversight. We lay eyes on them. We don't write them a prescription and say, see you in 30 days.
Yes. Yes, excellent. That's great. That's great, yes. Okay, so you mentioned a little bit here that you do other things besides just give them the medication. Tell us a little bit about that. Do you offer support groups, counseling? Are you in partnership with any other facilities at all where you might, refer off to?
Yep.
Those types of things?
Mm-hmm. We currently have 3 licensed substance abuse counselors on staff, and we provide both individual counseling, group counseling, for patients who have family members that want to participate in their treatment and who the patients are comfortable having as part of their treatment. We offer family counseling. We've done couples counseling because a lot of people who are addicted are in partnerships with someone else who is also addicted, and so they have the challenge of getting sober together.
Yes.
That can create its own stresses. We offer different types of counseling depending on individual needs, and we have been very pleased with the community response to our presence. We have a good relationship with the sheriff's department. We have good relationships with some of the local sober living facilities, and we've developed some good relationships with some other providers in the area as far as medical care and things of that nature.
Okay, great. Are there requirements to? Is the counseling, is the therapy just offered, or is it kind of a requirement?
It is required.
Okay, excellent. That's great to hear. And then, are there other requirements to continue? Do they have to take a drug test?
Yes.
Do they have to
Yes.
check in with somebody?
We require random drug screens on a monthly basis. So they at least one. So they'll have at least one drug screen, which is random on a monthly basis. They're required to participate in counseling, and they are, of course, required to, attend, regularly, and they have interaction on a daily basis, when they come in with our nursing staff, because we have a nurse who dispenses them the medication. So, they're, it's really very much a wraparound kind of approach.
When a person starts methadone treatment and then chooses to continue it for, past that 30 days, if you will.
Sure.
Do most people end up staying on it long term? Do they think about it as being long-term treatment? Do they think it's just a stepping stone to ultimately, be abstinent?
Okay. So the average person who enrolls in methadone treatment and sticks with it, past that first 90 days, is in treatment for approximately 2 to 3 years. That's the average treatment episode, and it's been shown that for someone whose ultimate goal is abstinence, that really you need at least that long in treatment for your for abstinence to be successful long term. A lot of people can come in and leave treatment earlier than that, but they don't necessarily maintain their abstinence. And as to whether or not it's a long, I think 2 to 3 years is considered long term anyway. But as to whether or not it's a lifelong thing that someone should do, really depends on their history. Some people, may not have an extensive history of drug abuse. Other people come to us and they've been using their entire lives, and for that person, I don't know that abstinence is a realistic goal. So you really just have to, assess the individual and what their motivation is, and you have to respect what their goals are. And some people, like being here. It works for them, and they don't have any desire, to come off the medication. Other people, want to get off the medication. So, we have to tailor the treatment to the individual, not a forced direction, if you will.
Okay, so this to me is one of the more important questions, because I do get this a lot in, with the SHARE project and working with other parents personally, and the people that I interact with and am trying to encourage to get into treatment, those types of things. They use this phrase that turning to methadone, some kind of medicated assisted treatment, is just trading one drug for another. Can you help me with that and what I could say to someone, and how do you encourage them to not choose it for that reason?
Okay, so I think the best answer I can give you to that question is we have to distinguish between addiction and dependence, okay? If someone is addicted to a drug, okay, that drug, interferes with their functioning at every level of their life, okay? You see a deterioration, in how they're able to function in society. They, essentially, chasing their drug becomes their full-time job. That's addiction, okay? All right. When someone is on medication-assisted treatment, what they have is a dependence, okay? Now, there are lots of medications that produce dependence, okay? We've got millions and millions of Americans who take antidepressants, okay? If you stop taking an antidepressant, all of a sudden, there's going to be you're going to have withdrawal effects from that. Different than narcotic withdrawal, but withdrawals nonetheless. If you're diabetic and you take insulin, you can't stop taking insulin.
True.
You have to keep taking insulin. So, people who are on medication-assisted treatment, have a dependence, not an addiction. And so that's really, so no, we're not replacing, one drug with another. It's a completely distinct, choice, treatment.
Yeah. Okay. How do you, yourself, in this field, how do you measure your successes? And what kind of keeps you going from day to day? What keeps you from being discouraged? What keeps you encouraged and motivated from day to day?
I measure success, by when I see someone enter treatment, and I see them, on that day that they come in for admission, I see, just the look on their face and their whole presentation. You can just tell they've been suffering, and they are, they're at that place where they feel, just totally hopeless, helpless, and then they start treatment, and I see that same person again 2-3 weeks later, and they're different. They are a different person. Got a smile on their face, and they look healthier. They'll look you in the eyes. I've just seen people just completely transform, and so seeing that transformation, that's success for me. Take somebody from that place where they were on the day they were admitted to, seeing them in a better place a short time later. Now, officially, the way we measure success is by, how effective we are at getting people off of illicit opiates. And I can tell you that at this point in our history, and it's a relatively short history, I realize, but at this point in our history, 90% of our patients, more than 90% of our patients, who have been in treatment for 6 months or greater have discontinued use of illicit opiates.
Wow, that's a great statistic. That's great. Yes.
We're proud of that.
Yes, you should be. Yes. Do you find there is a stigma surrounding your job title?
Yes, yes. There's a lot of stigma. People have a lot of preconceived notions about what this type of facility is, and as you can see, because you're sitting here, if you look around, this looks very much like a doctor's office. It's nothing like what most people think of, when they think it's going to be like when they step through the door. And people have heard horror stories, and I'm not saying that some of those stories aren't true, but what I'm saying is the only people they hear about are the horror stories.
Yes.
Okay, so it kind of taints their
Yeah.
perception,
Mhm.
because the other people who are participating in treatment that are doing well, guess what? You don't hear about them.
In your extensive experience that you've been doing this for quite a while now, and then maybe specifically to this area, what are some things that we could do better in this area as far as treatment facilities, those types of things? What do we need more of? What would you say on that front? What do we do good? What could we do better?
So, really, I think in this area, and this is part of our mission, is to reduce stigma in the community, which is one of the reasons why I'm doing this interview. Really, I just want everyone to really think about the fact that every patient who comes here, that's somebody's son, daughter, mother, father, sister, brother. They are someone to somebody, and they are human beings, and they need to be treated with dignity and respect. They have a disease, and it's a treatable disease, and that's what we're trying to do here is help them treat that disease. So that's really the thing. They're just people should congratulate if someone has the courage to admit to someone that they're on this kind of treatment. People should congratulate
Yes.
them rather than look down their nose at them. So there's just a general acceptance of individuals who are trying to get better that needs to occur. And as far as services, I think the biggest gap that I really see in this area is in terms of psychiatric treatment for our population. There's just not a lot available, and we have so many patients that have co-occurring disorders.
Dual diagnosis.
They're dual diagnosis, and there just aren't a lot of resources for them.
Okay, any final message at all? I think that was pretty good about the stigma part. Anything else at all, or is that it?
I just thank you for doing this.
Thank you. Thank you.
It's I appreciate the opportunity to get this message out, and to anyone out there that is watching this and you have a loved one who may be suffering with this disorder, we're here to help, and we'll do whatever we can for them. So that's it.
All right. Well, thank you very much for your time today, Brian. And we are going to do a tour, so stick around for a part 2. And I thank you for your time.
Absolutely.